To all participants attending this summit around the world, good morning and good evening to all of you. I'm Armando Enriquez Jr. from USAID's Medicines, Technologies, and Pharmaceutical Services or MTAPS program in the Philippines. On behalf of USAID's MTAPS program and the Department of Health Philippines, I'd like to share with you the experience of the Philippines in responding to COVID-19 through the reconfiguration of the supply chain to balance equity and emergency response during the pandemic. Let me begin with the challenges in managing procurement and supplies in the national context. I'm sure most of us here would agree that despite the global initiatives to strengthen the resilience of supply chains, it seems that most countries were not ready for the ripple effects of COVID-19 pandemic, especially in the healthcare setting where PPE and laboratory supplies were greatly affected due to a sudden increase in demand. In the Philippines, shortages of essential supplies were observed because of the disruption in productivity and mobilization in the overall supply chain network. And on top of that, the already challenging status of the supply chain management in public health became more difficult to handle in the context of responding to the pandemic because of the existing gaps in data visibility, which emanates from the lack of coordination and predicament in obtaining timely and accurate flow of information. As a preliminary response, the Interagency Task Force on Emerging Infectious Disease or IATF was convened by the order of the President to attend to public health threat brought by COVID-19. One of the initiatives made was the creation of the Task Group on Resource Management and Logistics or TGRML to oversee the procurement, allocation, and distribution of essential supplies in response to the pandemic. USAID's MTAPS program has been working with the government in strengthening its supply chain management capacity for public health programs even before the pandemic. Now, when COVID-19 crisis emerged, the MTAPS program launched its COVID-19 response project to provide further technical assistance to the Department of Health in establishing and maintaining its resilience in the context of public health emergencies. It started in February 2020, when scoping and technical assistance expansion transpired to cover emergency supply chain management. In March 2020, MTAPS and TGRML began the reconfiguration of the national supply chain management by revising the inventory policy to ensure a more frequent stock requisition and distribution. Simultaneously, the DOH created a mobile operating system-based data collect application, which they called the Bed Tracker. That serves as a medium to collect data on inventory of PPE, beds, and mechanical ventilators at the facility level. And to supplement that further, MTAPS and DOH collaborated to incorporate a dashboard that they called Commodities Dashboard in the Data Collect app that can oversee the stock status of PPE at the facility level, which then became a vital consideration in decision-making during procurement and distribution of PPE. In May 2020, MTAPS supported the DOH and TGRML in the deployment and implementation of Data Collect app and Commodities Dashboard through a series of web-based training, which includes topics about emergency supply chain management at the facility level. During this time, MTAPS and DOH also began conceptualizing possible updates that can be done to further improve the functionality of the system. As mentioned, the Data Collect app is a mobile application used by the designator personnel at the facility level to encode the inventory of their PPE on a weekly basis. Upon encoding, the information is stored in the central server of DOH, where it is readily extractable by the application programming interface to project as a dashboard. The information gathered by the Data Collect app is also the basis for the COVID-19 tracker to project the number of cases and available beds at the facility level as reference to the public and to the national government. Here's how the commodities dashboard looks. This serves as an early warning tool to determine which among the facilities need immediate stock replenishment through map visualization using their location coordinates. The commodities dashboard has features that allow users to project all or specific areas and items in the map. It presents the stock status for a specific item within a selected region, province, or facility type. The dashboard can also project the stock requirement for facilities for the succeeding weeks, which serves as the basis of the national government for stock allocation and replenishment. During this period, from May to September 2020, there were a total of 1,841 healthcare workers from 136 COVID-19 facilities trained nationwide on emergency supply chain management and data collect app. So far, there have been no stockouts or COVID-19 essential supplies after the implementation of the data collect app, and it greatly helped TGRML in planning stock allocation and distribution. Moving forward, the DOH, with the support of NTAPS, developed a supply management tracking system as an upgraded version of the Data Collect app, where additional features such as the improved visualization on data, quantification, and donation management were incorporated. This is expected to be implemented nationwide within November 2020. So next step would be to continuously venture into upgrading the system and the dashboard to further improve the critical components of emergency supply chain and include appropriate allocation and monitoring of new COVID-19 products such as laboratory equipment, supplies, and reagent. These also can open opportunities to address data management gaps in other public health programs like TB, HIV, and malaria, among many others. Data Collect app used in the Philippines was highly useful. Using the application, 98.8% of treatment facilities reported on a daily basis on hospital beds occupancy and stock status of COVID-19 commodities. From the introduction of Data Collect app until now, no major stockout of COVID-19 commodities was reported at the healthcare facility level. So in conclusion, in the absence of a functional logistic management information system, the mobile phone-based Data Collect app can provide a viable solution for essential stock data visibility to balance equity and emergency response. That's all for my presentation. Thank you so much for your time. If you have questions or clarifications, we will be very happy to attend to those.
Good day, everyone, and I want to thank you for joining my meeting this morning or this afternoon, depending on wherever you are joining us from. Thank you once again. This is the title of the presentation, National Integrated Specimen Referral Network, NiSRN, in Nigeria, responding to the impact of COVID-19 challenges. It's presented by Theophilus Faruna, the Director of Lab Logistics Program with Camonix Nigerian program. Thank you. So, Specimen Referral Network through the third-party logistics in Nigeria. GHSC-PSM implements NiSRN on behalf of the Nigerian government using a private sector third-party logistics providers to transport specimens and test results to and from health facilities, as well as the testing result getting back to those labs. The program, funded through PEPFAR and the Global Fund, covers all the 36 states of Nigeria, as well as the Federal Capital Territory, Abuja. It's a nationwide program that is structured to meet the needs of more than 119 million people in Nigeria. NiSRN is designed to transport samples for analysis, and after the analysis, return those results back to those facilities where the patient sample were taken, so that the patients can be adequately attended to by the clinician that sent them for the testing. and this is for HIV and TB program currently. The aim of NiSRN is to enhance access to clinical diagnosis. As we all know, not everyone living in the remote areas have access to clinical diagnosis because most of these equipments are located in the urban cities. Not even all the urban cities, but clearly in Nigeria, we have about 17 labs that are being supported by Global Fund and PEPFAR mechanism in the country. These are the places that these tests could be carried out free of charge to the patients. And in order to reduce operational costs, NiSRN was set up because it is not possible to set up all these high-tech equipment laboratory in all the various hospitals in the country. And setting them up in a limited place where access could be granted to almost everyone, wherever you're located in the country, we believe will reduce the cost of the operation. Another aims that is being achieved through NiSRN is the reduction of turnaround time for sample analysis. That is from the time the sample is collected from the patient and passing through the chain of custodies, being transported to those labs, and when the results are ready, the result being taken back to those healthcare facilities where the patient samples were taken from. We saw that previously, before NiSRN, it takes as long as 2 months for the result of samples that were taken in one particular locations to get their results back. But with the advent of NiSRN operation, that has been greatly reduced. The turnaround has shrunk as low as 1 week in some instances, and on the average, about 2 to 3 weeks. We also aim that the NiSRN provide a secure specimen referral services such that the integrity of the sample is maintained, the environmental hazard is contained, and also the hazard to personnel, either the one transporting the sample or those who are within the vicinity of where the samples move through, are also safe because of the triple packages that is carried out before the samples were moved. As you can see from the pictures on the screen there, the transporters have a container at the back of the motorbike with a bag that is already containing the specimens, and the specimen even inside that blue bag also has a container that contains them. So this is the measure of triple packaging to ensure that the environment is safe, the persons or personnel that are moving the transport are also safe from any hazard that could result from the biorisk of the samples. Let's understand the impact of the COVID on our sample transportation a little bit. As we have pointed out earlier, this study seeks to understand the impact of movement restrictions and the social distancing due to the COVID-19 pandemic on the sample referral program in Nigeria. We saw that when the COVID pandemic started in a bigger way in Nigeria, especially in the month of April, May, June, down to July, there were a lot of strategies being put in place by the government of Nigeria, not only in Nigeria, all over the world, to ensure they curtail the spread of the pandemic. That led to restriction of movement. In fact, in some places, 24 hours curfew were put in place to ensure that people do not move around in order not to be contaminated or to contract the virus, as well as there was a total shutdown of flights and other mode of transportation in the country. This we saw that could have an adverse effect on sample transportation, not only sample transportation, but all the activities in the country, as we saw that even the economic situation in the country was almost paralyzed. But then that will not stop patients from being sick, and that should not stop people from caring for patients. And so NiSRN try as much as possible to see what could be done in order to circumvent those challenges and yet provide the robust services that NiSRN is known for. The sample types that NiSRN normally provides services for are viral load samples, as you all know, the 95 strategy of UNAID, to ensure that at least 95% of people who are on viral load, who are on antiretroviral therapy have a viral suppression. We also do dry blood spots from infants, diagnose infants that are born by people who are infected with the virus, to ensure that even the prevention to mother transmission strategy that's in place is working or not working. CD4, cluster of differentiation type 4, is also a mechanism of measuring the viral replication in the system, as well as TB sputum for TB diagnosis. These are the samples that NiSRN deals with in Nigeria. All of these have been transported in an integrated manner, thereby saving the cost of parallel transportation of samples in the system. Specifically, we saw the corrective action that we took to overcome the challenges. One, for movement and travel restriction, and then for social distancing measures, as well as flight suspension. GHSC-PSM obtained written authorization from the Federal Ministry of Health and other relevant security agencies, including approval from police, for police escorts in some instances where it is necessary in order to be able to transport samples and thereby encountering less hindrances along the path of the transportation of those samples and results getting back to the facilities. We also did performance monitoring using phone calls, using other method of communication like Zoom network, as well as Hangouts and other method of communication that were available to us to ensure that we're monitoring the sample transporters wherever they are on a daily and a moment by moment basis to be sure that the samples were actually going to those places they're supposed to go. Those challenges, those strategies that we put in place actually provided a lot of dividend. That despite the challenges, NiSRN grew even during the COVID-19 lockdown time in the country. The number of samples and results transported during the first month of COVID-19 was still above the average number of monthly samples and results that were being transported before the COVID pandemic. From the graph there, you could see that before before the COVID era, we were normally doing about 69,000 samples on a monthly basis and 65 results, 602 being returned on a monthly basis on the average. However, during the time of the COVID, we discovered that we were even moving more samples. As you can see, 91,806 samples were moved during the months on a monthly basis or on the average monthly, while we have 77,946 results returned on a monthly basis during the time of the lockdown between April, May, June, July, and even August. What is the lesson that we learned from all that we did? Despite COVID, we were still able to do what we did. Sample referral programs require national government buy-in. That was the key lessons we learned from what happened in that period. That without the government backing, giving us authorization, allowing the police escorts and other stakeholders providing input, calling them when they were supposed to answer us and they answered us, it would have been so difficult to move sample during that time. We also had stakeholders corporations. There are a lot of stakeholders, the facility personnel, the third-party logistics providers, who are the private people that we engage with, also provided a lot of corporations. We also had supervisions. The funders supervising us and the GHSC-PSM staff doing all they could do on the field to ensure that those who are the foot soldiers on the field were actually doing what they were supposed to do. This collaboration made it possible to secure authorization letters from the government and the police escort to mitigate the challenges of intra and interstate movement. We continue constant communication with partners, use effective monitoring of services, a real-time feedback mechanism for prompt intervention, and performance review with GHSC-PSM, with the third-party logistics and NiSRN team through visual platform. All of this provided us as a lesson that we plow back into using it for further activity. We saw that reprogramming the NiSRN strategy while working closely with the host government resulted in uninterrupted clinical sample transportation, especially using document authorizing movement where restrictions were put into place. And with this, the success of transporting HIV and TB specimen effectively through NiSRN mechanism necessitated the Nigerian Center for Disease Control and some state government engaging NiSRN to transport COVID-19 samples. Having done all the things that we did during lockdown, it became obvious that NiSRN is a way to go, even to transport the COVID sample that needed to be moved from various locations to other places. And so NiSRN was contracted, and we deployed the strategy in about 5 states in June. In June, we operated in 2 states of Oyo and Kano, and we moved about 4,714 in Oyo State, 323 in Kano. In the month of July, we increased to about 4 states, Niger State, Kaduna State, Kano State, and even Plateau joining. And from there on to August, to September, to October. And at the end of about October 16, we saw that we have transported about 22,727 samples of COVID from various locations in these 5 states to the testing centers. And the result communicated back via electronic method back to those centers that were coordinating the sample collections in all of these places. And currently, with the sources also deployed here, the government of Nigeria, when the National Youth Service Corps returning back to the camp in this early month of October, we were also engaged to be able to move sample from the NYSC camp to the testing center, so that we are sure that the NYSC Corps members that are coming to the camp also have access to COVID testing in order to curtail any outbreak of COVID because of camping for national orientation, national youth service program in the country. So these are all that we've been able to do with NiSRN, and despite COVID, we have provided services that is as robust as when there was no COVID. Thank you very much. Thank you for listening. We are open to questions.
Did you have anything you wanted to add to your presentation, Theophilus, after the...
So, I was waiting in case I have any questions to take up. Thank you everyone for staying put to listen to the recording. I was scared that there won't be network for me to do a live presentation. So basically, we have seen that the program that we run, the National Integrated Specimen Referral Network, despite the COVID, we were still able to maintain the services that we were doing. And we have moved from the history of this program, close to 2.3 million samples have been moved within 2 years. And a lot of patients have benefited from that services at a shorter turnaround time compared to what it used to be before the program came on board. That's just what I would just forget to add now, except I have more questions from other people or clarification that is needed for me to provide. Mohit, over.
I have not been given any questions on top of that.
Hello, sorry.
Yep, go ahead.
Yeah, thanks so much, Theophilus. I'm Lusubilo Malakibungu from Tanzania. I'm so happy to see the sample referral system. It's one of the areas that has been working on. So I'm really curious to know, despite the COVID-19, so were people free, like the patients and the people who seek for services, were they free to come to the care and treatment center, maybe to get their sample for viral load, or their sample for TB testing, or HIV/LA infant diagnosis? Were they allowed to move around, or were they free to come to the service center to have their sample collected? And were they not fearing like to move freely because as I can see in my place here, most of the people were fearing to go to the hospitals because they know there is one of the risk area to visit. And also, I wanted to know if you were also doing any kind of a community visit to get these samples, because I know also there are some patients who are under multi-month scripting for their ARVs, so they might come to the.
Okay, thank you, Lusubilo. You asked a question and you have indirectly answered some of the questions. Yes, it was a difficult time for people to come to the hospital that period, but then those who were on appointments, because there are clinic days on which people need to come to collect either their drug or for their blood sample to be taken for the viral load assessment, they were still allowed to come to the hospital. And then the second thing that was used in getting samples was that we have also people that move around within the community to be able to get those who are due for testing to collect their sample for it to be transported to the places for analysis. So these two things actually played out. Either those who were able to come to the hospital, because once you have a card and you show that, look, today is my clinic day and I need to go to the hospital, they will allow you to pass to go to the hospital, apart from those who are afraid of going to the hospital. So those type of people will collect their blood sample. And those who were not able to come, there were a mechanism for local people around to go to their houses and schedule a time to collect their blood sample and transport to the centers for testing. Those were the two strategies that were employed. Thank you.
So I'm Vincent from Tanzania. Thank you, Theophilus, for the update from Nigeria. I'm just wondering whether there is nothing that was done in terms of the resources that were allocated in supporting the sample collection and transportation apart from the government buy-in, because my understanding is that whenever you have any intervention, what comes first should be the government buy-in. So maybe there is another factor which contributed to the increased performance during the COVID. I was just wondering.
Okay, thank you. Yes, you are very correct that if there's a program, there should be a government buy-in. But one of what had happened in situations like this is that because a program is always have a buy-in from the Federal Ministry of Health, but then you know that those who are normally the security agencies that are on the road to enforce lockdown or restriction of movement, some of them may not have an idea of what the government is doing with that program. So that was where the stakeholders engagement with government coming out with a pass, a kind of a documentation to allow those who are on these services to move around freely and be able to carry out their services. And one other thing that also increased the number of samples that were taken around this time was that because there was a lockdown, so more people have access to be able to be attended because they were not going to work. All they need to do is to go to the hospital or someone visit them to collect their sample. So we saw that. And then in terms of movement along the road, because the road were a little bit freer at that period, it also contributed to the number of samples that were taken within that period. Those were the two factors that majorly play out during that time. I don't know if that's
yeah, thank you.
All right, thank you.
All right, well, thank you for those questions. We're now actually going to move to the third presentation that we have for the day. And after that, we'll open up to all three presentations and Q&A from there. Our final presentation for the day comes from, I believe, Michael. And Michael, you have sent me your presentation, so I will share my screen and then you can begin your presentation.
Yeah, thank you. Hi, everyone. Yeah, I'm Michael Kishiwa from Tanzania. I work for the Global Health Supply Chain Technical Assistant project in Tanzania. I'm here to take you through the presentation on the strategies that the project implemented during the COVID-19. Next slide, please. In 2016, the JAE, this is a joint evaluation, was conducted in Tanzania that assessed the country's capacity to prevent, detect, and correspond to the response to the public health emergencies. This resulted into identifying the gap in emergency supply chain. And in 2019, the Technical Assistance Program, a project in collaboration with the Ministry of Health, began to develop the Tanzania Emergency Supply Chain guides that was developed to respond to the gap that was identified in 2016. We all know that in March 2020, that's where the pandemic was declared by WHO, and in 2016, Tanzania recorded its first confirmed case of COVID-19. At the same time, now we had already in place the materials that the Tanzania Supply Chain Emergency Operation Guides. So the project prioritized it. We strategized it and prioritized into the contingency plan for the country. The country also had the contingency plan in place. That was the contingency plan for 3 months, by March to June. So one of the intervention in the contingency plan was to operationalize the Tanzania Emergency Supply Chain Operation Guides. So we worked together with the Ministry of Health in collaboration to identify how we could operationalize. So we agreed to implement the Tanzania Emergency Supply Chain guide that has both response and preparedness strategies. Next slide. So we identified 4 strategies to work together in collaboration with the Ministry of Health. And one was to disseminate the materials. So we printed and disseminated around 1,500 copies to different stakeholders, including the implementing partners, and also oriented some of the stakeholders who are at the front line. The other intervention was on the forecasts and the supply planning. So this intervention was achieved by the project in collaboration with the Ministry of Health, where all the pipelines and supply plannings, we adopted the tools from the WHO that was customized to reflect the Tanzania context. So we worked with the ministry together to keep on triage of the stock on hand, tracking the shipments, and any new gap that were identified in the shipment was resolved. So we had people who are committed to keep monitoring on the supply planning and then updating the forecast. The other was to work on the data visibility. This was also became as a challenge because we had a system that was specific for the COVID commodities. So we needed to configure the existing electronic logistic management information system to have a platform for the COVID-19 commodities. So a dashboard kind of was created, although this is taking sometimes longer because we came to complete it by end of June. The final strategy that we used was the capacity building, where we developed a number of materials, a lot of materials on the commodity management, and trained the front healthcare workers, particularly the regional pharmacists and the lab personnel who are at the front line, and the health facilities who are managing the health commodities for COVID-19. Next slide, please. So this is how the information was flowing during the COVID response. We had the facilities that were identified to provide, because not all facilities were providing services to the COVID patients. Only few identified facilities, and these facilities we are consolidating all their requirements and sending them to the medical officers for authorization. And the designated facilities was sending direct their request to the public health emergency officer to the Ministry of Health, where they are scrutinized, and or if they had no problem, were approved. And after the approval, we are sent to the central medical officer, the central medical store department, where all the distributions of health commodity were originating. And if the requests had problems, then there are communication between the designated facilities and the emergency operations center at the Ministry of Health, the immediate corrections, and they send it back to the emergency operations center. The emergency operations center was sending the orders and the request to the central medical stores for packaging of the order and the distribution. Next slide, please. Sure, we have a number of lessons. So that's one. Number one was to formalize the formalization of the coordination between the pillars. We noted that the emergency operations center had 2 points of contact, and each pillar from the partner side and from the government side. We needed to work together between the logistic pillar on the partner side and also on the government to ensure that we have the information that is shared. And the other thing was to, as I said before, that the pipeline coordination was very important, because we noticed that we had a lot of incomings. So we needed to consolidate all these orders, all those incomings. So it was important to have few people who are committed to deal with the pipeline flowing in the supplies. So MSD also required received a lot of data. So this data were used to determine the supplies of commodities in different parts. So all the reports and all the upstream and downstream data information reports were required to ensure that we do not have the duplication of commodities in the system. Apart from that, also we had to clarify some of the formalize reporting practice for both international and the local procured commodities. We had some SOP like the donation guidelines that were used for checks and by control of commodities before they come in the country. So we required some of the partners or who are willing to donate some commodity or to procure some commodity to go through the donation guidelines that are required to bring in the commodity in Tanzania. Also, we have in any international procured commodities should be addressed to the permanent secretary to ensure that the data visibility of incoming shipment is aligned. In collaboration also with the private sector, we recommended that the private sector should be engaged in the coordination of all logistics. So we had several meetings to ensure that the private sector also were engaged to share their guidance and identify if they had any stock in place that could be leveraged to the supply. One of the lessons was to collaborate with the other affected countries to share quantification approaches. This is very important because in our country, of course, we used the WHO quantification tool, which were customized in the Tanzania context. So that tool was adopted in the country. We used it as one of the tools specific for Tanzania. We learned that the tool that is developed at the international could be used just as a guide to other countries to adopt, and it's important to tailor it to the context of each local needs. During the period also, we had to develop a lot of material for training of frontier care workers, like I mentioned, the commodity management materials at the health facilities. All the training were done virtually. So it was also a learning for us that instead of the face or in-person meeting that had already been happening in the system, now we have to change to focus on the virtual training materials. So we developed materials and we conducted a training to about 8 participants in the country, in all regions. This brings me to the end of my presentation, and thank you for the attention. If you have any questions, please, I'll answer them. I have also my co-presenter, Emily Maguno.
So Michael, I do have a question for you from the chat. I think it's Gashaw. I'm sorry if I'm mispronouncing your name, but they were asking, how do you approach your quantification differently, the fact that there are lots of unpredictable situations?
Yeah, thank you, Mahit, for that question. And to going straight to the question, how to the approach of quantification differently. The fact was that the Minister of Health always was issuing the different approaches to how to quantify, because they developed a list of commodities, of course, because we understand that COVID was a new thing. So every country had no standard treatment. So the Minister of Health provided the list of commodities that would be used for management of COVID cases. So this helped us in developing some of the assumptions and also regarding the approach that the country was using. So we didn't go to the test all, but we were only suspects that were reported are the ones that were tested. So this one were the assumptions that we are included in the quantification module, and that's why I say that we managed to put it in the local context so that we have a demand, and this was agreed through different meetings with partners. Thank you.
Shah, I hope that answered your questions. Do we have any other questions? And I'm going to open this up to all 3 of the presentations. So if you had a question about the first presentation we had or anything like that, please go ahead and ask.
Okay, so I have a question to the presenter from the Philippines. My understanding in most countries have some emergency preparedness plans and the guidances. And I'm just wondering whether Philippines is one of those countries with such a plan, and whether their plan includes aspects of health commodity supply chain. And the key question is whether, to what extent, if they have, their preparedness plan was relevant to COVID, and if not, what was the gap, and how have they managed to address it for future use?
Thank you, Vincent, for that question. Well, yes, USAID MTAPS program is in collaboration with the Department of Health Philippines even before the pandemic. So the program started to strengthen the regular supply chain of the government in terms of its engagement with public health programs or providing medicines in the context of public health programs. So it also involves emergency supply chain management. However, when COVID-19 emerged, the Philippine government, specifically the Department of Health, is not ready, just like many other countries. So the approach actually is the speed to respond, right? So as I've said during my discussion a while ago, is that it involves a lot of coordination and commitment to pull off the response. So data management, data gathering, provision of training via virtual approach, and provision of support at the facility level are some of the initiatives that the national government provided and coordinated with the USAID AMTAPs. So, yep. We also have here our country director, Has, and our senior technical advisor in USAID AMTAPs, Gashaw. I'd like to ask if you have additional inputs. Thank you.
Yeah, I can come in here. Can you hear me?
Yes, Gashaw.
All right.
Yes, I can hear you.
Thanks, Armando. Yeah, we do have from the onset when we are asked to shift a little bit of our regular activities in supporting response to COVID. The first thing we did was scoping visit and develop a draft strategy hinge into close to 5 strategic objectives. And one of the critical strategy which helped very much was the governance part. If you look at Armando's presentation, there was a command center reporting to the president's office. And there are multi-sectorial involvement, particularly when we revise the system. We make it more frequent, knowing that our strategic objective basically is to have an equitable distribution, not efficiency from the onset. I'm anticipating there will be a lot of revision in the coming months so that when the challenge related to global and local shortages are coming down, we may have a little bit, less frequent distribution. So to address the resource requirements, if you look at, when you think of more frequent distributions, there will be a lot of, more frequent visit and distribution to the facilities, which requires a lot of resources. And the Office of Civil Defense comes in as part of under the President's office supporting the operation. And that was really very helpful. To add on the implementation, like you see almost 100% reporting rate. In the Philippines, the work ethics and the flow of commands are very well structured, and department orders were issued to every facility with a simple procedure: what to report, how often they are going to report, what tools they are going to use. And immediately we developed the e-learning platform, starting first with WebEx and Google Meet, and then we scale it up to have an e-learning platform. And to the extent people in the neighboring countries actually participated in some of the trainings. So the team really did an amazing job in country, and then coordination, I would say, plays a great role to bring the success. Over.
Wonderful. I think in the chat, Susan had a question. Susan, you can unmute yourself and go ahead and ask a question.
Sure. Thank you very much. I thought, thank you very much to all of the speakers. I thought it would be helpful if they could maybe just each of them share one thing that in hindsight they would have done differently. Thank you.
Okay, so maybe let me go first. What is it that we could have done differently looking back? I think one thing that I think we could have done differently was the issue of ensuring that we communicate better earlier before or during the pandemic. The communication was not as robust as we have wanted it to be. So if we have any other opportunity again, when we have this situation on ground, we would like to communicate more with all the stakeholders so that they understand the reason, the purpose, why, what we want to do, why they should cooperate with us the more to achieve a better result than what we have had so far. And then another thing, we'll look at which area will have advocate for more funding in order to be able to reach out to those that were not privileged to be able to come out for their sample to be taken during the COVID or during the lockdown session. That's two things that I think we have done a little bit different from the way we handled it that time. Let me give my other speakers the opportunity to also come in. Thank you. Over.
Hi, this is Emily. I was one of the co-authors of the presentation that Michael Kashiwa gave, that third one. Just kind of going along the lines of the second presenter's comments, I think that we learned the importance of formalizing communication and identifying specific points of contact in advance that can be communicated with during the event of an emergency. I know in Tanzania, we had worked to develop the Tanzania Emergency Supply Chain Operations Guide well in advance of the COVID-19 pandemic. But I think when we look to improve that so that it is still a viable preparedness strategy that has been strengthened in order to respond to the next public health emergency, we'll really look to formalize those communication channels between, for example, various pillars of Tanzania's Emergency Operations Center, and then within all of the kind of stakeholder groups that are involved in coordination to a epidemic or pandemic response, making sure that there's a specific point of contact established for each of those stakeholder groups that is responsible for handling incoming questions from other groups and responding to them. So really just formalizing the communication channels and making sure that there's a point of contact within each stakeholder group specifically responsible for that communication with other stakeholders, because it ended up being a lot of work to coordinate the communication between all of the stakeholders. And it was important for us to make sure there was one person with that designated responsibility to make sure that the communication and coordination was successful.
Thank you, Emily. Do we have any other questions? Anyone else want to jump in here and ask any questions to the three groups of presenters? Thank you all for joining our talk and our track from all over, and hope to see you guys at the networking event. Thank you.
Thank you.
Thanks, everybody.
Thank you, everyone.
Thank you. Goodbye.
Bye.
Bye-bye.
Bye-bye.
Bye-bye. Thank you.
Yep, thank you.
Bye.